Hello everyone, welcome to the clinical scenarios, the next pattern questions, and this is your case number 10. Now here we have a 75-year-old African American man, okay. So basically they are telling you the race also. He is coming to your office for his annual checkup. I think now you should be clear that why they told you that he is an African American man, because in India it's hard to find that a person coming for the annual checkup, okay. Now he is a known diabetic and a hypertensive. You know, these are the rich man's diseases, so very common at this age. His medications include the lisinopril and the atenolol. Vitals normal. Examination of this fundus shows the cupping of the optic disc. Visual field examination shows constricted peripheral vision. What is the most likely diagnosis? Your options are diabetic retinopathy, closed angle glaucoma, macular degeneration, or primary open angle glaucoma. Now if you look at this patient, he is a 75-year male. He is not having any much of the problem. He has just come up with the annual checkup, okay. Now he is a known case of diabetes and hypertension, but it is well in control. He is on lisinopril, he is on atenolol, vitals are normal. Now just on screening we are getting the cupping and the constriction of the peripheral visual field. Now first of all, what do you mean by cupping and what does it indicate? Cupping means that you are having the optic disc atrophy. So you are having the optic atrophy, you are towards the optic or very appropriately if I say, it is actually the optic disc changes. So we are having not the atrophy, it is the optic disc changes that we are having. So if I am having the optic disc changes, along with this also I have constricted peripheral visual field defect. So I also have the visual field defect. So can you see what are these changes? Basically they are pointing towards the glaucoma. They are pointing towards the glaucoma because you have a peculiar triad of glaucoma. And what is that triad? Triad says that you should have raised intraocular pressure with the optic disc changes and with the visual field defect. So out of the 3 criteria, 2 is a must that we study. That 2 criteria out of the 3 means that it is actually glaucoma, and here they have already given you 2 criteria. They have said that there is a cupping of optic disc, there is a constriction of the peripheral vision. So our diagnosis is basically going towards the glaucoma. Now which glaucoma? Which glaucoma? See, angle closure glaucoma is actually an emergency. It is an emergency condition. This will lead to the sudden as well as painful diminution of vision. So that you are not having. Moreover, angle closure glaucoma is more common in females, especially at 50 years of age. So they are manifesting much earlier in the 5th or 6th decade, and you have certain risk factors. So we will be comparing the risk factors. If you compare the risk factors, whether this patient has more chances of open angle glaucoma or the angle closure glaucoma. So on one hand I have primary open angle glaucoma, on the other hand I have primary angle closure glaucoma. So what are the risk factors? This is equal in males and females, while angle closure glaucoma is definitely more common in females. This is more common after 60 years of age, this is more common after 50 years of age, right? Then what are the risk factors for the open angle glaucoma? We have diabetes, we have hypertension, both of which are given in the question. Then we have thyrotoxicosis. Then we have CRVO or we have BRVO, we have smoking and the myopia. So all those people who are having the genetic predisposition, so that is common because glaucoma usually runs in the families. So all those people who have this genetic predisposition in the open angle glaucoma, it is the optineurin and the myocilin. There are two genes which are responsible. They are located on chromosome number 1. So we have the risk factors. He is a male, more than 60 years, having diabetes, having hypertension. So I have enough of the risk factors to say that it's an open angle glaucoma, because you know the primary open angle glaucoma is also called as chronic simple glaucoma. It is also called as the chronic simple glaucoma. So basically it is not an emergency condition, it's not an acute condition. So this patient has not manifested himself with lot of diminution of vision till now, but signs are there. So we are having the typical triad out of which two things are seen. On the other hand, if I talk about the angle closure glaucoma, this is actually causing the sudden as well as the painful diminution of vision. This is causing sudden and painful diminution of vision. This is more common, which is not there. Then it is more common in females, that is not there. Around 50 years of age, that is also not there. Then it is more common in those people who are having the hypermetropia, hypermetropes, having the shallow anterior chamber, or those who have small eyeballs, or we have the small cornea. So all those people who have some predisposition towards the shallow anterior chamber, hypermetropia, all these people are more having chances of angle closure glaucoma. So I think this is completely ruled out. Angle closure glaucoma is not actually expected in a patient who is 75 years male, not having any problem. He has just come up for the annual checkup. He is having the diabetes and hypertension under control, and he is coming with the cupping and constriction of the visual field. Another important thing is that in cases of angle closure glaucoma, because you know angle closure glaucoma happens to be an acute disease, these things are very unlikely. Like acutely you will not get the optic disc changes, the cupping of the optic disc. You are very unlikely to get the constriction of the visual field, because all these changes actually requires time. So it has to be chronic. Okay, now we are left with the diabetic retinopathy and macular degeneration. Now if I talk about macular degeneration, you know macula is the most sensitive part of the retina, and macula is one part which is actually responsible for the central vision. So I think this is very unlikely that if a patient is having some macular disease and it is going unnoticed, he is not complaining of anything, and he has just come up with the annual checkup. See, I have picked up an image where patient is actually having the macular degeneration. Can you see this area? This area is the area which is looking like when the patient is having this macular degeneration. So you have a distorted vision loss in the center, rest of the periphery is normal. So I think this is very contradictory to the question, because you know question is saying that there is a problem in the periphery. There is a constriction of the peripheral field, but here if there is a macular degeneration, that will show you the constriction in the center, the distortion in the center. So that means we can easily rule out this macular degeneration and we can rule out the angle closure glaucoma. Now what about diabetic retinopathy? Now if you see, they say that this patient is 75 years old and he is on treatment for diabetes and hypertension. They have not tell the years, the duration, but suppose I think that they have been diagnosed 10 years later, and even if the treatment is going on for the last 10 years and he has developed the diabetic retinopathy, but actually they are not talking about the diabetic retinopathy, because diabetic retinopathy will not lead to the cupping of the optic disc or the constriction of peripheral visual field. Diabetic retinopathy will lead to what? If the patient is actually having the diabetic retinopathy, then first he will be showing the NPDR, and the moment this patient develops the NPDR, this patient will actually be showing you the microaneurysms. Okay, so if they are talking about the microaneurysms in the question, or they are talking about the dot and blot hemorrhages in the question, they are talking about the hard exudates, okay, or what are the things that you get? You get the venous changes. We get a lot of venous changes like I can have beading, I can have looping, or I can have the irma. Microvascular changes can also be there. Then I will be thinking in that respect of diabetic retinopathy. Moreover, this will lead to the gradual diminution of vision also, but this patient is not presenting with any of these things. So it's very unlikely that the examiner is trying to ask me the diabetic retinopathy. Now, two important clues that they have already given you is the optic disc changes and the visual field defects, and that is actually required for the diagnosis of your primary open angle glaucoma, going up with your two important risk factors, diabetes and hypertension. So we can clear cut say that this is a case of primary open angle glaucoma. Now let us try to see what are the optic disc changes that they are talking about. They are basically talking about the cupping. So what do you mean by cup? See, this total is your optic disc. Try to understand what is this. This is your optic disc. Optic disc is something which you are seeing intraocularly. Okay. So if I have suppose the optic nerve. So we have something like this optic nerve. Okay, so this optic nerve, suppose this is the eyeball sclera, it is coming out. Okay, so when you see the intraocular part of this optic nerve, you see a circular area, the cross section, that is actually called as optic disc, and optic disc is also called as optic nerve head. So basically it is the head portion, the intraocular portion of the optic nerve that you can see. Now this optic disc is actually made up of nerve fiber layer of the retina. How many layers does retina has? 10 layers. So out of 10 layers, nerve fiber layer is making this optic disc. So this area that I am able to see, can you see? This area that I am able to see here is actually showing me the thickness of this nerve fiber layer. So I have this area, I have this area, I have this area, and I have this area. So what are these? These are actually the thickness of the neuroretinal rim. So that is actually showing you the health of the optic disc, because if I have more and more optic atrophy, when you get the optic atrophy, then I will get the thinning of this neuroretinal rim. So in the beginning, when the optic disc is healthy, I do not have any problem. What is there? It actually follows what is called as ISNT rule. Isn't rule says that this is actually thickest. This is number 1. Then I have next to it is the superior, then third is your nasal, and then fourth is the temporal. So what happens? This is ISNT rule, the thickness. If I talk about the thickness of the neuroretinal rim, then it goes in this order. Normally the optic disc has this kind of thickness. I have maximum in the inferior quadrant, then in the superior quadrant, then in the nasal quadrant, and then in the temporal one. Okay, so what is happening when there is glaucoma? When there is glaucoma, there is more and more optic nerve atrophy. There is atrophy, there is a death of fibers. What happens? There is ganglionic cell death. So there is ganglionic cell death. So how it is taking place? With the help of apoptosis. This is taking place with the help of apoptosis. So when we have the ganglionic cell death taking place by the apoptosis, these fibers are getting atrophy and atrophy. So what is happening? The hole or the cup, this area was the cup. This is your disc and this is the cup. So this area is now increasing. So what is happening now? Slowly and gradually cup will increase and what will happen? Therefore, the neuroretinal rim that I was having in the periphery will get thinning and thinning. So from the car tire, the thick car tire, it will be changing to a cycle tire. There you have got a large cup and you have got a very thin tire. So actually the optic disc changes in the glaucoma typically can be simulated from a car tire to a cycle tire. So what happens when there is an increase in this cup size? Then it does not follow this ISNT rule. It does not follow. It does not say that because I have to maintain this rule, so I will take less of the fibers from inferior, then I will then this. No. So it is actually not following this ISNT rule. Slowly and gradually we have a large cup and this cup is actually vertically oval. Why it is vertically oval? Because first there is a loss of superior and this inferior fibers. So because superior and inferior fibers are going first, that is why you have first elongation of this cup in the vertical direction. Afterwards, when we have the loss of this nasal and temporal also, then this cup will also grow horizontally and therefore you will have the horizontally oval. So first it is vertically oval, then horizontally, and then again there will be superior inferior fibers going again. So that is why you get a typically vertically oval cup in cases of open angle glaucoma. Now if I talk about the visual field defects that are expected to occur in the patient of glaucoma. So what happens if I talk about a normal visual field? What is actually a normal visual field? Normal visual field is actually present in the form of isopters. It is present in the form of isopters. So isopters means you have got so many areas in which the visual acuity is present, something like this. So these are called as isopters or isopters of the vision. So what happens if you concentrate in the center? We have got something called as this blind spot. Blind spot. See, if I divide my visual field into 4 separate quadrants, so we have superior quadrant, inferior quadrant, nasal quadrant and the temporal quadrant. Maximum that we can see superiorly, maximum that we can see inferiorly, maximum that we can see nasally and maximum that we can see temporally. So it is actually following what you called as S-NIT. So this is different from ISNT rule. That means it is actually minimum in the superior, that is 50 degree, then it is nasal 60 degree, then it is inferior 70 degree and maximum we have temporal, that is your 90 or it is 100 degree. Okay, so what is happening now? I showed you the optic disc. So the optic disc, suppose this is your retina, and we have got one of the layers, suppose this is your nerve fiber layer which is forming your optic nerve. Okay, so can you see there is a hollow which is formed here? So this area you do not have retina because the retina has led to the formation of the optic nerve. So if something has fallen at this space where you have got the vacuum, there will be no image formation. And what is this area? This is the anteriormost portion of the optic nerve, that is your optic nerve head. That means this optic nerve head will actually cast a vacuum in our visual field, and you know that visual fields are always diagonally opposite. Now if you look at the eyeball, how it is going, if you look at the eyeball, if it is now if you look at the eyeball, how it is going to form the visual field, see this. This is your nasal retina, this is your temporal retina. So what happens, the optic disc is always present on the nasal side of the retina. So it is not exactly in the center, it is tilted somewhat towards the nasal side. And you know the macula or the fovea centralis, this is present towards the temporal side. Okay, now that means the visual field that I am going to have from this nasal retina will be towards this temporal visual field, and the visual field that I am going to have from this temporal retina will be lying in this nasal visual field. Okay, so because you know that this optic disc is actually lying on the nasal side, so that means the visual field defect that will be present due to this optic disc, that is the blind spot that I am going to have, will be present. So where I will have this blind spot, that will be present in the temporal visual field. That is a very, very important concept, because many a times the students get confused that why do we have a blind spot in the temporal visual field. Are you getting this now? Because you know optic disc is always present on the nasal side and it is going to cast. So my nasal retina will always see towards the temporal side and my this temporal retina will see the nasal side. So if I have some defect on my nasal retina, that defect will be coming towards the temporal visual field. That is the reason why we will cast its visual field. If it is, this is the visual field, then this nasal will correspond to this temporal visual field. This temporal will correspond to the nasal visual field. Okay, superior, this inferior will cast this superior visual field and this superior will cast the inferior visual field. So this nasal retina is going to give a blind spot in this temporal visual field. Okay, now what is happening with the isopters? If you look at the visual field, I told you that our visual field is actually divided into isopters. We have like center, then we have 0 degree, 10 degree, 20 degree, 30 degree and so on. So when we have a problem with the optic nerve fibers, this will affect my visual field. Okay, so what is happening? As more and more fibers are getting atrophied, my horizon of vision is also decreasing. So it is starting from the periphery and now these isopters are constricting. If this was the amount to which I could have seen before, now it is becoming like this, then this, then this. So it is constricting. So what are the first defects that you are able to see is the peripheral visual field defects, and then slowly and gradually it is constricting, constricting, constricting. Then a time will come when you are able to see just the center one. That is called as a tunnel vision, as if you are seeing through a tunnel or a tube, because when you are seeing through a tube, you are not able to see the up, down, right or left. You are just seeing in the center. So that is left. Now if you see in the center also, what is the last area to go. So the last area to go is the temporal visual field, because this temporal visual field is actually marked by my nasal retina, and nasal fibers are not affected first. Then which fibers are affected first? So it is actually the temporal fibers which are affected first. Now what is this? Try to understand this. See, this is showing you the fibers. Don't get confused with the defect here. These are the fibers. So here we have got the optic disc. Okay, so we have this optic disc. So because this is the optic disc, therefore this side will be the nasal retina, and the other side therefore will become the temporal retina. That is very, very clear. So on nasal side I have got radiating fibers, superior radiating, inferior radiating, and on the temporal side I have arc-like fibers. Can you see these fibers? They are arc-like. So these are called as arcuate fibers, superior arcuate fibers and inferior arcuate fibers. So it is actually these arcuate fibers which are first affected, which are most sensitive to the glaucomatous damage. So because these arcuate fibers are most sensitive to the glaucomatous damage and they are present on the temporal side, so which vision will be affected first? So these temporal fibers will affect the nasal visual field first, and these nasal fibers will affect the temporal visual field, right? So you know that it is these temporal fibers which are affected first, so it is the nasal visual field which is going, and you had seen that amongst the cupping it was first the superior and the inferior fibers which were going. So superior inferior fibers have gone out of the nasal and temporal, it is the nasal one which is going first. So what is the last to go? Therefore the last visual field to go is the temporal visual field. So I hope now we are very, very clear. If you come to the case again, he is a 75-year male, he is coming just for the annual checkup, he is not telling you any problem. That was ruling out the macular degeneration. That was also ruling out the angle closure glaucoma, because angle closure glaucoma is actually manifested by some of the symptoms. He will not coming, he will not be asymptomatic, he will not be coming for just the annual checkup. Then his medications are there, so he is actually under control of diabetes and hypertension. Vitals are also normal, no evidence of infection, no evidence of any urgency. But the fundus details is showing you something which is called as cupping of the optic disc, and also we have the visual field defects that is coming from periphery. So out of the triad we are getting two important signs. One is the optic disc changes, one is the visual field defect, and that is how we reach to the diagnosis of glaucoma. We have ruled out diabetic retinopathy because you will not get cupping of the optic disc in cases of diabetic retinopathy. No other evidence of diabetic retinopathy has given. Angle closure glaucoma is acute condition that we have ruled out. Macular degeneration will not come with the peripheral constriction, rather it will come with the central constriction. So your answer is primary open angle glaucoma. Thank you and happy ophthalmology.